We're gonna start in a minute.
I'm not sure if is it my issue only or the others also you cannot hear.
We cannot hear Dr. Nader. We cannot.
Okay.
Hello everyone. Hi. Welcome to the Zoom
I'm not
meeting.
sure if
You
is
can
it my
start.
issue only or the others also you cannot hear.
We cannot hear Dr. Nader. We cannot.
You can.
Okay.
You can start now.
Okay. Okay, assalamu alaikum everybody. Today is Saturday, August the 30th. The Gray team will going to present. My name is Hajar Ali. The agenda for today is, let me share my screen. Yeah, yes. The first topic will be type 2 diabetes mellitus, will be presented by Dr. Azza and Dr. Tsion. Collaborative research, the second topic, how to build research collaboration and working in multidisciplinary teams. The third topic is their stories and how they succeed. The fourth topic will be giving feedback to juniors and others. The fifth topic is research method and example for that. Okay. And after that, we will discuss any updates or ongoing research projects, updates. That's it. Yeah. So the first topic is will be presented by Dr. Azza Ahmed and Dr. Tsion is type 2 diabetes. Dr. Azza, the floor is yours.
السلام عليكم. شكرا دكتورة هاجر. السلام عليكم دكتور نادر. السلام عليكم all followers. I would like to thank Dr. Nader for giving me this opportunity. I would discuss today diabetes type 2 and with Dr. Tsion. Let me share my screen. Is my screen clear?
Yes.
Yes, clear.
Okay, thank you. Thank you. Okay. Send. Bismillah ar-Rahman ar-Rahim. Type 2 diabetes. I would talk about definition, clinical manifestation, and diagnosis of type 2 diabetes. Table of content. This presentation will cover the following. Introduction to diabetes, understanding type 2 diabetes, the pathophysiology, and the clinical manifestation, diagnostic criteria and test, differential diagnosis, then the summary and key takeaway, the references. The introduction. Type 2 diabetes mellitus is a chronic progressive metabolic disorder primarily characterized by peripheral insulin resistance and the gradual deterioration of pancreatic B-cell function. This pathophysiological process culminate in persistent hyperglycemia and account for over 90% of all diagnosed diabetes cases worldwide. Type 2 diabetes is strong associated with the modifiable and non-modifiable risk factors, include obesity, sedentary lifestyle, and advancing age. It constitutes a major contributor to macrovascular and microvascular complication and remain a leading cause of cardiovascular morbidity and all-cause mortality globally. The Endocrine Society defined type 2 diabetes as chronic hyperglycemia due to impaired insulin secretion and action. Unlike type 1 diabetes, there is no autoimmune destruction of beta cells. Once it is gradual, and many patients remain undiagnosed for years. Metabolic and vascular disease, and it is not insulin dependent at early stages. And it's strongly linked to lifestyle factor. Okay, glucose metabolism in diabetes. In type 2 diabetes mellitus, insulin resistant limit glucose take in muscle and fat, while the liver continue producing glucose despite hyperglycemia. Elevated free fatty acid worsen insulin signaling and progressive beta cell dysfunction leading to decline insulin secretion. The key mechanism are decreased glucose uptake in muscle and adipose tissue, increased hepatic glucose production despite high blood glucose, increase the free fat acids, worsen insulin resistance, and the beta cell dysfunction reduce insulin output over time. The global prevalence of diabetes. The global burden of diabetes is rising rapidly, with type 2 diabetes being the main contributor. According to the International Diabetes Federations, more than 530 million adults worldwide are currently living with diabetes, and this number is projected to rise significantly in the coming decades. The United States has seen a steady increase in both incidence and prevalence, higher prevalence in low and middle income countries due to bandization, lifestyle changes, and limited healthcare access. Type 2 diabetes account for 90 to 95% of all diabetes cases globally. Its prevalence is increasing rapidly, as we mentioned before, particularly in low and middle income countries. Raising childhood obesity has contributed to earlier onset in younger population. Type 2 diabetes poses a major economic and healthcare burden due to its long-term complication. Global impact, 463 million adults affected worldwide, according to 2019, projected to reach 700 million by 2045. Rapidly growing in low and middle income countries, increasing prevalence in children and adolescents. Significant economic burden from chronic complication. The pathophysiology. Type 2 diabetes arises from insulin resistance and progressive beta cell dysfunction. Muscles and fat tissue become less effective at glucose uptake, while the liver produces excess glucose, as we mentioned before. Over time, the beta cells fail to meet insulin demand, with lipotoxicity, inflammation, and oxidative stress further impairing function. So insulin resistance leads to decreased glucose uptake in the muscle and fat, hepatic glucose overproduction despite hyperglycemia, and beta cell failure leading to decreased insulin secretion. All this leading to lipotoxicity, inflammation, oxidative stress, worsening metabolic dysfunction. The risk factors of developing type 2 diabetes is influenced by both modifiable and non-modifiable factors. The modifiable factors include obesity, especially central fat, physical inactivity, and excessive caloric intake. Non-modifiable risks, advancing age, the family history, ethnic background, higher prevalence in African, American, Hispanic, Native American, and Asian population. Additional risk factor, gestational diabetes, occur during the pregnancy, and polycystic ovary syndromes, hypertension, and dyslipidemia. Now we will talk about the common symptoms. Type 2 diabetes mellitus often present with a constellation of symptoms resulting from chronic hyperglycemia. Patients commonly experience polyuria, polydipsia, and unexplained weight loss, fatigue, blurred vision, recurrent infection, and are also frequently reported, reflecting the systemic impact of impaired glucose metabolism. So it's a polyuria, it's a frequent urination, and polydipsia, excessive thirst, unexplained weight loss, fatigue and weakness, blurred vision, and recurrent infection. Example, urinary tract infection and skin. Or many patients with type 2 diabetes are initially asymptomatic. When symptoms appear, they often include the classic triad, which is polyuria, polydipsia, and polyphagia. Other common signs are weight loss, fatigue, blurred vision, infection, and delayed wound healing. Diagnosis is frequently made during routine laboratory testing. Here are the symptoms, like the classic triad, and following symptoms: weight loss, fatigue, blurred vision, or recurrent infection, often diagnosed through routine labs. Okay, diagnostic criteria. Diagnosis requires one abnormal test result confirmed on a different day unless symptoms are present. Options include fasting glucose, oral glucose tolerance test, OTT, or GTT, and hemoglobin A1C, or random glucose with symptoms. Fasting plasma glucose more than or equal 126 milligram per deciliter, or 7 millimole per liter. The OGTT should be more than 200 milligram per deciliter. It's equivalent to 11.1 millimole per liter after 75 gram glucose. This test, you should be fasting first. So they will just draw first fasting blood glucose, and then after each hour, we'll measure it again. Hemoglobin A1C should be more than or equal 6.5, equivalent to 48 millimole per mole, and the blood glucose more than or equal to 100 milligram per deciliters with symptoms. This is the diagnostic criteria. The hemoglobin A1C test reflect average blood glucose over the previous 2 to 3 months by measuring glycosylation of hemoglobin. It is not affected by short-term fluctuation. So here it's a normal, should be less than 5.7%, and pre-diabetes will be ranging from 5.7 to 6.4%. Diabetes if it's more than or equal to 6.5%. Okay, let me discuss also the complication. If left untreated, type 2 diabetes mellitus leaded to both microvascular and macrovascular complication. The microvascular damage primarily affected the retina, kidney, and peripheral nerves, resulting in retinopathy, nephropathy, and neuropathy. The macrovascular complications include coronary artery disease, cerebrovascular accidents, and peripheral arterial disease. Additional consequence may involve recurrent infection, non-alcoholic fatty liver disease, and limb amputations. So the microvascular complications include, as we previously mentioned, retinopathy, nephropathy, neuropathy. The macrovascular complication, coronary artery disease, stroke, peripheral artery disease. And other complications include infection, non-alcoholic fatty liver disease, and amputations. Okay, I will talk about the acute complication. Acute complications are less frequently in type 2 diabetes mellitus than in type 1, but can still arise. This includes hyperosmolar, hyperglycemic state, which is characterized by severe hyperglycemia, profound dehydration, and altered mental status. Additionally, hypoglycemia may occur, particularly in patients treated with insulin or sulfonylureas. Hyperosmolar glycemic state, severe dehydration, altered consciousness, extreme hyperglycemia. The acute complication also, the hypoglycemia risk increase with insulin and sulfonylurea therapy. Okay, now the chronic complication, persistent hyperglycemia in type 1, type 2 diabetes, mellitus lead to chronic complication that affects multiple organ system. Microvascular, as we mentioned before, it's a retinopathy, nephropathy, and neuropathy. And the macrovascular, coronary artery disease, stroke, peripheral artery disease. Additionally, patients often experience impaired immunity. So that's it. And delayed wound healing and increased susceptibility to infection. Screening recommendation. Screening should begin at age 45 and repeat every 3 years if normal. Younger adults should be screened earlier if overweight with additional risk factor. And the woman with gestation diabetes need lifelong screening. Let's start at 45 age, repeat every 3 years, screen earlier if the patient is overweight and has risk factors. Gestation diabetes, first they will do screening within 6 to 12 weeks postpartum, and then every 3 years. Okay, now the differential diagnosis. Several other conditions can cause hyperglycemia and should be differentiated from type 2 diabetes mellitus. This include type 1 diabetes, characterized by autoimmune beta cell destruction, and the MODY, which is maturity onset diabetes of the young, immunogenic form of diabetes, and secondary diabetes resulting from medication. Cushing syndrome will present with hyperglycemia or pancreatic pathology. Here the bullet points: type 1 diabetes, autoimmune destruction, and the MODY, which is monogenic diabetes, secondary diabetes caused by medication, Cushing, and pancreatic disease. So in conclusion, type 2 diabetes is a chronic condition caused by insulin-resistant and beta cell dysfunction leading to high blood sugar. It accounts for most diabetes cases and is linked to obesity, inactivity, age, and genetic. Symptoms may be absent initially, but include frequent urination, thirst, and fatigue. Untreated type 2 diabetes cause microvascular and macrovascular complication and increased infection risk. Acute issue like a hyperosmolar state and hypoglycemia can occur. Distinguishing type 2 diabetes from other diabetes types is important. Early diagnosis and treatment are crucial to prevent complication. And this is my resources. Now, Dr. Tsion should discuss more treatment about the treatment type 2 diabetes. Thank you.
Thank you, Dr. Eiman. Sorry, Dr. Azza. Thank
No
you so
worries.
much.
Thank you. Thank you, Dr. Hatchet. Thank you so much.
Dr. Tsion?
Yes, can you see my screen? Sorry.
Yeah, yes, we can see.
Okay, thank you everyone. for this opportunity. So I will continue with the management of type 2 diabetes. So in general, type 2 diabetes management includes the patient education and evaluation for micro and macrovascular complication, which has discussed with the Dr. Azza, and also the treatments to achieve near normal glycemia control, and also minimization of risk factors, especially cardiovascular and other long-term risk factors. So all these goals and treatment options need to be tailored for patient individual factors like age and also comorbidity, as well as the patient's life expectancy. Based on this, we can plan the treatment goals according to the patient preference. So our treatment goals in type 2 diabetes, diabetes patients includes the glycemic management, as well as the cardiovascular risk factor management. So for glycemic management, we individualized our hemoglobin A1C target. So we have to balance lowering the immediate risk of hypoglycemia and adverse effect of therapy with minimization of the macrovascular risks. So our general goal is for most patients, our goal is to maintain the A1C level less than 7%. This is different for patients with older adult patients or those with comorbidities or limited life expectancy, because this kind of patients may not have a significant benefit for significant lowering of the A1C level. Rather, they may develop adverse effect of the drug with associated polypharmacy because of the other comorbidities. And every 1% A1C reduction have improved long-term outcome, but decreasing the A1C less than 7%, there is not that much increased microvascular risk if hemoglobin A1C is less than 7%. So we can maintain it less than 7% for younger, especially for age grade less than 60 years. But for patients with older adult comorbidity and limited life expectancy, we can maintain with less than 7%. And this reduction is mixed for the macrovascular complications. The study showed some are positive, other neutral, and there's also one study which has shown the harmful effect for macrovascular. So the benefit is mixed, and the other goal is cardiovascular risk factor management, like smoking cessation, BP control, and lipid management with statin, and healthy diet, exercise, weight control, like weight loss or maintenance of the weight, and aspirin for atherosclerotic cardiovascular disease after shared decision making. And the first thing in treatment is diabetes education. The one thing is medical nutrition therapy. This is tailored dietary plan based on the patient's medical lifestyle and personal factor, as we have discussed. All of our treatment options need to be tailored based on the patient individualized factors. And this is the 5 components of medical nutrition therapy: weight management and increased physical activity, caloric intake balanced with caloric expenditure, and consistency in day-to-day carbohydrate intake as meals and snack, nutritional content in timing of meals and snack. All these are the goal of avoiding weight gain, consistency in carbohydrate intake, and balancing nutritional content. And also, if needed, they are also important for weight loss. So these are the components of medical nutrition therapy. The other is weight management. So body weight is another key component in type 2 diabetes management. There are 3 strategies: lifestyle modification, pharmacologic therapy, and surgical therapy. We initially start with lifestyle modification and go to pharmacologic or surgical therapy if there is no response for lifestyle modification. And the lifestyle includes the diet and also exercise and behavioral support that the patient needs to achieve this diet and exercise behavior. And the other is, if there is no response with lifestyle modification, we got to start with pharmacologic therapy. Metformin, as we know, it is the first line for glycemia management, but it has also a modest weight loss effect. But if you want to manage weight loss as a primary treatment goal, we can use other treatment options like GLP-1 receptor agonist, that has more weight loss activity than metformin, or the other is dual GLP-1 on the glucose-dependent insulinotropic polypeptide agonist for significant weight loss reduction and glucose lowering. The last option is surgical therapy, the bariatric or metabolic surgery for poor response to lifestyle and pharmacologic therapy, and there are indications. And the other is exercise. This improves glycemic management independently of weight loss. It increases insulin sensitivity. So it has a better effect. The recommendation is to do 30 to 60 minutes of moderate intensity aerobic exercise, like greater than 150 minutes per week, spreading over greater than 3 days per week. And the other is if the patient has no contraindication, like moderate to severe progressive retinopathy, proliferative retinopathy, or severe coronary arterial disease, the patient can do resistance training for greater than or equal to 2 times per week. If there is no contraindication. The other is intensive lifestyle modification. So this combines caloric restriction, physical activity, and behavioral support. The benefits are weight loss and maintenance, improved glycemic control, reduced medication use, and non-cardiac improvements like quality of life, sleep apnea, and urinary incontinence, depression. These are all the benefits of intensive lifestyle modification. The other one is psychological intervention. So patients are predisposed to the developing distress or depression, what we call diabetes distress, because of the responsibility of managing several components of their life. So this psychotherapy, one study has shown that psychotherapy can improve A1C modestly and reduce psychological distress. So the goal is to support adherence to lifestyle, medication, and glucose lowering. So this, the 5, like medical nutrition therapy, weight management, exercise, intensive lifestyle modification, and psychological intervention are the main component of diabetes education. Then we go to the pharmacologic treatment. So on the timing of to start pharmacologic therapy, the recommendation is to start for patients with the A1C level at a baseline greater than or equal to 7.5 to 8. We have to start pharmacologic therapy at diagnosis. But if the patient has clear and modifiable cause of hyperglycemia, like if the patient is taking high sugar sweetened drinks, and if the patient is committed to change them, we can give the patient 3 months trial of lifestyle modification before initiating pharmacologic therapy. But if the patient has A1C at baseline or diagnosis less than 7.5%, and if the patient is highly motivated, then we can link the trial 3 to 6 months of lifestyle modification before the medication. So these are the indication. Then when you select the initial therapy, it depends on the patient presentation, whether this patient has symptoms of hyperglycemia or not. And the other is baseline A1C level and relevant comorbidities. And also the patient's treatment goal and preference. And the other is the drug characteristic, the glucose lowering efficacy of the drug, the adverse effect profile, tolerability, and the cost. So we have to consider these things on deciding initial therapy for patients with type 2 diabetes. So the first thing is based on symptom. If the patient is asymptomatic, not catabolic, no symptom of polyuria, polydipsia, or weight loss, and if the hyperglycemia is found on screening in routine labs, we can start with metformin as a preferred initial therapy. We can start with 500 milligram once daily with the evening meal. Then if tolerated, we can add another 5 milligram with breakfast, and we can have gradual titration in every 1 to 2 weeks, and we to achieve as 2,000 milligram per day. So metformin is the preferable first-line therapy unless contraindicated, or if the patient has strong indication to use another medication class based on other comorbidities. So why metformin is preferred as initial therapy? Because it has a strong glycemic efficacy. There are many studies that has evidence for this. And the other is it has also promotion of modest weight loss. And it has very safety profile, very low hypoglycemia risk, and no adverse cardiovascular effect. Even may have lowering the cardiovascular event. And the other is cost effective and widely used. So compared with other classes, lower cost than the GLP-1 receptor agonists or SGLT2 inhibitors, and fewer side effects like less weight gain and hypoglycemia. It has modest weight loss, as we discussed, compared to sulfonylureas, and also less edema, heart failure, and weight gain than the thiazolidinediones. So our approach is stepwise. So we start with metformin, 500 milligram once daily at the mealtime of the evening. Then we can add another agents only as needed. So the cardiorenal benefit of the GLP-1 receptor agonist and SGLT2 inhibitor not proven in drug naive no risk patients. So we have to start with the metformin. So when metformin is not an option, or it's contraindicated, or another drug class is indicated, our approach is we assess comorbidities first, like if the patient has atherosclerotic cardiovascular disease, heart failure, diabetic kidney disease, obesity, hypoglycemia risk, and cost. We will assess these things, and we will consider the shared decision-making approach. It guides our selection based on the efficacy, risks, and patient preference. The first thing is, if the patient has atherosclerotic cardiovascular disease, the preferred ones are GLP-1 receptor agonists, because of many studies have shown the benefit on the favorable outcome of this atherosclerotic cardiovascular disease. We prefer these drugs, the subcutaneous or oral semaglutide, dulaglutide, and liraglutide. The alternatives are the SGLT2 inhibitors, particularly if heart failure is present. These are also shown proven benefit, especially for heart failure hospitalization and also for reduction of the mortality and also for reducing kidney disease progression. So the preferred one, GLP-1 receptor agonist, the alternative one are SGLT2 inhibitor. For these patients, we have to consider the cost, the insurance coverage, A1C level, and patient motivation for weight loss. Then the other is if the patient has heart failure or diabetic kidney disease, the preferred ones are SGLT2 inhibitors at kidney protective dosage. So studies have shown that these SGLT2 inhibitors have decrease the disease progression for diabetic kidney disease. It decreases heart failure hospitalization, and also they decreases the mortality. So these are the dosage proven to have kidney protective effect: empagliflozin by 10 milligram, canagliflozin 100 milligram, and dapagliflozin 10 milligram. So we have to avoid initiation if estimated GFR is less than 30 to 45 ml per minute per 1.73 meters square for glycemic management, because they are dependent on the estimated GFR. So they don't have effect on the glycemia. If you initiate when the GFR is less than 30 or 30 to 45, but kidney and cardiac benefits remain. So we have to avoid SGLT2 inhibitors in patients with frequent UTI or yeast infection because of increased risk. We have to avoid low bone density, foot ulceration, or high decay risk because of the increased risk associated with SGS drugs. And the other is, if the patient is KD stage 4, estimated eGFR is less than 30, the preferred agents are the first one, insulin. So when we use insulin, we have to adjust the dosing, like we have to use most of the total daily dose to the daytime, because there is a risk of nocturnal hypoglycemia, especially in patients with chronic kidney disease or end-stage kidney disease. The other is the dipeptide peptidase 4 inhibitor, the linagliptin. This one is the only one that doesn't need the kidney failure adjustment. And the other is GLP-1 receptor agonists, can be used cautiously. Educate patient on dehydration from because they have risk of nausea and satiety. Patient may have dehydration and may be predisposed to developing acute kidney injury. So we have to avoid that in patients with, especially for CKD patients. So we have to use cautiously these agonist drugs. And the other is repaglinide. This has also acts on the sulfonylurea receptors, but it is short-acting, so it has decreased risk of hypoglycemia, and it's also primarily metabolized by liver. So this is another option. And just the other is short-acting load of sulfonylurea glipizide. It has low hypoglycemia risk because it is short-acting than the long-acting agents like glimepiride. And the other is obesity or obesity-related comorbidity for these patients. So GLP-1 based therapy is effective for patients with obesity-related comorbidity, especially sleep apnea or metabolic dysfunction associated steatohepatitis. So because of the decreased appetite, they have good effect for weight loss. And this tirzepatide, this is a dual drug with the glucose-like peptide 1 receptor agonist, and also the dual one, the glucose-dependent insulinotropic polypeptide. So this has better for weight loss than the other semaglutide, the tirzepatide drug. So alternative therapy when metformin is contraindicated, we choose therapy based on efficacy, comorbidity, patient preference, and cost. So if A1C level is greater than 9%, we consider insulin or GLP-1 based therapy for initial, because these drugs, the insulin and GLP-1 based therapy, have better glycemic efficacy than other drugs. And in the other case, if the patient hemoglobin A1C is less than or equal to 9%, the other options include sulfonylurea, SGLT2 inhibitors, and dipeptide peptidase 4 inhibitors, repaglinide, and pioglitazone. These are other options. So we can decide on this based on the other factors. Like if the patient needs weight management more as initial therapy, the GLP-1 based therapy can be preferred. As we discussed, they have better effect on the weight loss, and the other option is SGLT2 inhibitors. They can also promote weight loss. So then we initiate lifestyle intervention before starting the other drug, sulfonylurea, to reduce weight gain risk, because sulfonylurea, the effect is it increases insulin secretion. So it may have weight gain risk. So we have to start lifestyle intervention along with the sulfonylureas. The other is the cost. So the low cost options are the short and intermediate acting sulfonylureas like glipizide and glimepiride, and the other is pioglitazone in case of sulfonylurea contraindication. So choice balances efficacy, availability, and risk of hypoglycemia and weight gain. Then we have to educate patients on adjusting medication with diet and activity to minimize hypoglycemia. The other is if our factor is hypoglycemia risk, and the special consideration, the low hypoglycemia risk options are the GLP-1 agonist, SGLT2 inhibitors, DPP-4 inhibitors, and pioglitazone. So, and if the patient has the metabolic dysfunction associated steatohepatitis, we can use pioglitazone that can improve fibrosis, inflammation, and steatosis. GLP-1 also is beneficial, and we have to monitor for side effects. For the pioglitazone drug, there is a risk of weight gain, fluid retention, fracture, bladder cancer risk, and there is also a risk of heart failure. So we have to control this. The other is, so we have discussed for patients with asymptomatic non-catabolic hyperglycemia, and the other is symptomatic or severe hyperglycemia, like fasting glucose greater than 200 or consistent random glucose greater than 300 and or A1C greater than 10%. In this case, our preference is for insulin, and also the patient have to reduce carbohydrate intake and hydrate with sugar-free fruit. So, and the other is if ketonuria, weight loss, or possible type 1 DIM, the additional thing is, in this case also insulin is preferred than other drugs. The alternative initial therapies, if the patient has no ketonuria and weight loss, and type 1 DIM is unlikely, but if the patient presents on symptomatic or severe hyperglycemia, we can have an option of GLP-1 based therapy in addition to insulin, with or without metformin. Metformin alone is not effective initially, but can be started concurrently. So in this case, if you cannot use insulin or GLP-1 as a third agent, you can use hydrosulfonylurea as alternative. So these are the drugs for these patients. So when we started insulin, hydro is often needed to suppress hepatic gluconeogenesis by increasing basal insulin. So we will monitor the morning fasting glucose. And the other one, when we start with GLP-1 agonists, we start at lower dose and we titrate slowly based on tolerance. And sulfonylurea, for better effect, we can start with higher doses. So the glycemic efficacy, most immunotherapy reduces the A1C level by 1%. Metformin more effective than the DPP-4 inhibitor, rapid initial response with the sulfonylureas, and long-term durability is the rosiglitazone has more effect than metformin, which has more effect than glyburide. So the cardiovascular benefit, the benefits are proven for the GLP-1 agonist and SGLT2 inhibitors, which can decrease heart failure hospitalization, the mortality associated with cardiac disease, and the microvascular benefit, all treatment improving glycemia, reduce risk of diabetic kidney disease and albuminuria, and GLP-1 agonist and SGLT2 inhibitors slow eGFR decline and prevent worsening of albuminuria. So for monitoring, we have to monitor hemoglobin A1C 2 times a year if at goal, but for patients who have not at goal, or that if they change the therapy, we can monitor quarterly in a year. And the other is blood glucose monitoring is optional for stable patients, but for patients with insulin users or with they want behavioral modification, they can monitor frequently. The next section is when to add a second medication in type 2 diabetes. We can add a second agent if glycemic goals are not achieved within 3 months on metformin and lifestyle intervention. This selection is guided by comorbidity and evidence-based benefit of specific medication classes. And these are for younger patients without complication, the A1C is less than 7%, as we discussed initially. And for older and those with comorbidity or limited life expectancy, we have to increase our threshold to 7.5 to 8.5%, because these patients may not have the expected benefit. Rather, they may have the adverse effect and the associated polypharmacy risk. And to achieve this hemoglobin A1C less than 7%, our conventional glucose targets are the fasting glucose 80 to 130, and the postprandial 90 to 120 minutes after meal should be less than 180. but 5 to 10% of patients per year may lose this target after initial therapy. These are the cause of rising glycemia: non-adherence to diet, exercise or medication, weight gain, diabetes progression, intercurrent illness, medication increasing insulin resistance like glucocorticoid or atypical antipsychotic, and another case, incidence of type 1 DM like latent autoimmune diabetes in adults, and the other is delayed or absent medication adjustment. So we choose our second line therapy based on whether A1C is greater than 9% or the symptom. If the patient has first-hand symptom of hyperglycemia, our preferred agents are basal insulin therapy or GLP-1 based therapy. Insulin is effective, especially in catabolic insulin deficient diabetes. And the alternative one is GLP-1 receptor agonist, effective alternative when type 1 diabetes unlikely, like for patients who was obese. So it has also weight loss benefit. And the other is for patients with A1C level less than or equal to 9%, we have to do shared decision making guided by the risk and benefit of medication, comorbidity, and patient preference. These are for patients based on comorbidity, as we discussed, for patients with established atherosclerotic cardiovascular disease or high cardiovascular risk, the GLP-1 receptor agonist has preferred agent, and the alternative ones are SGLT2 inhibitor. For patients with heart failure or diabetic kidney disease, we have to use renally adjusted. The preferred one is SGLT2 inhibitors, and we will use renal adjusted dosage. Now, there is for patients with obesity, we can use GLP-1 receptor agonist as a first line, especially tirzepatide, that is the dual drug, and the other option is SGLT2 inhibitors. When we want to avoid hypoglycemia, our options are GLP-1 receptor agonist, SGLT2 inhibitors, dipeptidyl peptidase 4 inhibitor, and pioglitazone. If the patient has fatty liver, the other option is pioglitazone, which can decrease the fibrosis and associated inflammation. And the other option is GLP-1 receptor agonists. So when this dual agent failure, the other case, the next part, the persistent hyperglycemia on two agents. In this case, if the patient has not started yet the insulin, we can start insulin or we can intensify. And also, we can often simplify regimen by removing sulfonylurea or less effective oral agents like DPP-4 inhibitors. And our options are triple therapy options like 2 oral agents or a plus GLP-1 based therapy. We do not combine DPP-4 inhibitors with GLP-1. These have the same pathway. They act on the same pathway, so there is no benefit. The other is 1 oral agent, usually metformin with basal insulin and GLP-1 based therapy. The other is 3 oral agent, metformin, short-acting sulfonylurea, and SGLT2 inhibitors. So we choose individualized by glycemic target, hypoglycemia risk, comorbidity, weight, side effect, and cost. So as we discussed for cardiovascular and kidney consideration, we can start with GLP-1 receptor and SGLT2 inhibitors. The other is for combination. We have to avoid adding SGLT2 inhibitors solely for hyperglycemia because these drugs have the low glycemic efficacy. So we will add the polypharmacy and cost risk. So we have to avoid. But the other is we can't use DPP-4 inhibitors with GLP-1 agonist as we discussed because they act on the same pathway. DPP-4 inhibitors reduce the metabolism of the GLP-1, and GLP-1 agonist also acts on GLP-1 receptor. So the effects are the same. There is not that much benefit. The other is with starting basal insulin, there are options like the intermediate acting NPH and the long acting glargine and dogludex. We can use this, and when we start insulin, we can continue the metformin, the GLP-1 agonist, or DPP-4 inhibitor, SGLT2 inhibitor if the patient is using this drug. But we have to discontinue sulfonylurea because this has the same effect as insulin, like it increases insulin secretion. So there is adverse effect profile of weight gain when we use with insulin. The other is pioglitazone. Pioglitazone also has a risk of weight gain, and also there is a decreased benefit compared with other combination. So we have to monitor blood glucose once or twice daily initially when the patient uses insulin, and we can adjust the dose every 3 to 4 days based on fasting glucose. And when the patient has persistent hyperglycemia on basal insulin, we have to review diet and exercise. Our next option will be adding rapid-acting insulin before the largest meal or multiple meals. And the other one is adding GLP-1 receptor agonist. And at the end, we can switch to premixed insulin twice daily. So these are the intensive insulin regimens like the other options. The patient can use multiple daily injection for insulin deficient type 2 diabetes. This may require insulin pumps that we use for type 1 diabetes, also continuous glucose monitoring and automated insulin delivery. The importance is they have higher serum insulin, so they have better glycemic control, but these high doses may can lead to substantial weight gain. The other is we can use concentrated insulin. The doses will be small, but the effects are higher. So the options are the insulin glargine and regular insulin for high daily insulin needs. The benefit are smaller volume, so better absorption, and we can consider insulin sparing agent for bariatric surgery if obesity worsen in this case. These are my references. So if you have any question, we can discuss. So thank you very much.
Okay, thank you. Thank you, Dr. Tsion and Dr. Azza, for this important topic. You explained it very well. Thank you. If there is any question? If no question, we will go to the next topic in agenda is building research collaboration and working in multidisciplinary team, presented by Dr. Malaz Bakri. Dr. Malaz.
Hello, everyone.
Hello.
Can you hear me, Dr. Hajar? Well,
Yes, yes.
good. So I'm gonna share my screen now. You see my screen?
Not yet.
Okay, good. I'm very honored to be with you today. My name is Malaz Bakri, and I'm from University of Khartoum. In this presentation, I'm going to talk about.
Sorry, Dr. Malaz, we can't see the screen actually.
Okay. Okay, now you can see it?
Yes.
Good. So, as I said, I'm going to talk about how to build the research collaboration and work in a multidisciplinary team. So, first of all, we will discuss what is collaboration in research. Research collaboration is systematic integration of knowledge and methods and perspective from multiple disciplines to address a complex scientific questions that transcend traditional academic boundaries. I.e., in other words, it's a cooperative efforts where multiple individuals, institutions, or organizations work together to achieve common research goals by pooling their expertise, resources, and knowledge. So we have knowledge integration, which include combining expertise from multiple fields to create comprehensive understanding. And also we have shared resources, i.e. pooling equipments, data, and methodological tools for enhanced research capacity. And innovation catalyst, like fostering breakthrough discoveries through cross-pollination of ideas. So what is the nature of collaboration in research? Research collaboration exists on a spectrum from simple coordination to deep integration. with each level offering different benefits and require varying degree of commitment and structural changes. So we have multidisciplinary collaboration, which means multiple disciplines work on the same problem independently with minimal integration of approaches or findings. We have interdisciplinary lines where disciplines integrate their approaches and methods to create a more comprehensive understanding of complex problems. We have the transdisciplinary lines creates new theoretical framework and methodologies that transcend traditional disciplinary boundaries and compete. So we have a communication strategies across different fields. So as we are like a team, we are doing research, we have to establish a common vocabulary. This is very important to create a shared glossary of terms and concepts, especially for the people who do not talk the same languages, and it's common in research teams. So we ensure all team members understand key terminology from each discipline represented. The second thing is the use of visual communication tools like diagrams and flow chart and conceptual maps to bridge language gaps and make complex idea accessible across disciplines. Also, regular check-in sessions like schedules, like to schedule frequent team meeting that focus on knowledge sharing and progress updates and addressing any communication barriers that arise. We have also to document everything. This is very important for the teamwork. Maintaining a detailed record of decision, methodological choices, and rationale to ensure transparency and continuity across the team. So the next thing, we're gonna take a look on the challenges and barriers in cross-disciplinary collaborations. We have this language and terminology barriers it can face us. So each discipline has a specialized vocabulary and conceptual framework that can create communication gap and misunderstandings between the team members. So as we said, we have to set lines and use a common language to be understood or common terminologies to be understood by all team members. The second thing is the methodological differences. Varying research approaches, data collection and methods and analytical frameworks for the people who come from different disciplines can lead to conflict over research design and interpretations. So to solve that, we have to set common tools to be shared by all the team members. Also, we have institutional and funding constraints, this like academic structures, promotion criteria, funding mechanism often favor single discipline research, creating systemic barrier to collaboration with other researchers. Time and collaboration complexity, managing schedules across different institutions, reconciling varying projects, timeline, and coordinating resources allocation require a significant effort. So next, we will take a look to a very important thing, which is tools and technologies for remote research collaboration to overcome these barriers. What should we do? We have the cloud-based data sharing platforms like Google Drive and Dropbox and specialized research repositories enable secure real-time data access, version control across teams. This is to ease the data sharing between the team members. Also, we have the virtual meeting platforms like Zoom and others, specialty tools like Gather facilities, regular team meeting, workshop, and collaborative analysis sessions. Also, project management system, tools like the Slacks and other things. These can coordinate tasks and track progression and maintain communication across different time zones and institutions. Collaborative analysis tools, platforms such as Studio Server and specialized software also enable real-time collaborative data analysis and modeling. This is also very important. So we need to know the essential skills for effective team collaboration. Active listening from all team members and the team leader. Developing the ability to truly understand perspective from different disciplines, asking clarifying questions, and demonstrate genuine interest in diverse viewpoints. This helps to bring all the team members together. Also, we have the intellectual flexibility, remaining open to new methodologies. This is especially for the head of the team, and questioning assumptions and adapting research approach based on input from team members with different expertise. Translation skills, learning to communicate complex disciplinary concepts in accessible language, and finding common ground between different theoretical frameworks. Also, we have the project coordination, maintaining timelines, resources across multiple disciplines while maintaining research quality and meeting diverse stakeholder expectations. So how to build a trust and respect among team members. Foundation for successful collaboration, trust forms the cornerstone of effective multidisciplinary research. Trust between the team members and the team leaders. So team members must feel confident that their expertise is valued and their contributions are essential to the project's success. And respect for diverse perspectives means acknowledging that each discipline brings unique insights and methodological strength that enhance the overall research quality. So we have to establish ground rules like clear expectations and mutual agreement on collaboration principles. We have to foster the learning and create opportunities for team members to learn from each other. And we have to recognize contributions, actively acknowledge and celebrate each member's unique expertise, and we have to maintain transparency by open sharing of challenges, concerns, and decision-making process. So the next step is how to implement collaborative practice in our research. We have to identify the collaboration opportunities, i.e. we need to map our research question to identify where other disciplines could provide valuable perspectives or methodological approach. We need to build our network, attend interdisciplinary conferences, join cross-departmental initiatives, and actively seek connections with researchers from complementary fields. And we have to start small and scale, being with pilot collaborations or joint publication before committing to large-scale interdisciplinary projects requires significant resource and coordination. And this is the end of my presentation. If anyone has any question, please go on.
Thank you, Dr. Malaz, for this informative presentation. If no questions, we will going to the next topic is research methods, presented by Dr. Eiman Ahmed. Dr. Eiman?
Yes, I'm here. Thank you so much, Dr. Hajar. Let me share my screen with everyone. Can you see my screen?
Yeah, we can see. Yeah.
All right. All right, Assalamu alaikum everyone. I'm going to be presenting the research methods in clinical field, foundation, and practice. So first, we start by the question why clinical research methods matter. So clinical research serve as the cornerstone of the evidence-based medicine, determining the safety and efficacy of treatment devices and diagnostics that impact millions of lives daily. When executing with methodological rigorous, these studies produce reliable, valid results that directly improve patient care while expanding our collective medical knowledge. So looking at the clinical research process, a stepwise journey. For step number 1, we see observation, and it's identifying a health problem or a phenomena through a careful clinical observation and preliminary data gathering. Then we have to have an association, which is exploring relationship between factors using statistical methods to identify patterns and correlations. Third is the causation, establishing cause-effect link through controlled experiments and advanced study design. Fourth, we have the intervention. We're testing treatment or preventive measures with careful monitoring of outcome and side effects. And fifth is the evaluation, where we assess outcomes and impacts through comprehensive data analysis and interpretation. So the types of clinical studies, we do have observational and experimental. So in observational, we have research, monitor within intervention, observing nature outcome. These fall within, the studies that fall in that category are cohort studies, case-controlled studies, and cross-sectional studies. For experimental, the studies that fall within that category is randomized controlled trials and non-randomized trials. So for cohort study, we see the follow group over time. The case control, we compare groups with and without disease. And for cross-sectional studies, we examine population at a single point. Randomized controlled trials are gold standard, and non-randomized trials are assessment without randomization. So looking at a snapshot of health in cross-sectional studies, we see that there is a population and then single time point, exposure assessment, outcome assessment, and stimulus measures. So the advantages of this are, is they're quick, relatively inexpensive to conduct, and effectively estimated disease prevalence. Limitation cannot be established, temporal sequence or causality, and prone to recall bias. Moving to the case control and cohort studies. In case control, the direction is retrospective. We look forward. Backwards. The process identifying cases with outcome and selects control without outcome and compare past exposure. The advantages is effective for rare disease and requires few participants. For the cohort study, we do have direction it's either prospective or retrospective. In case of a prospective cohort study, we observe a participant group, we measure them and record from the beginning of the study and follow through forward in time through to the point of time of the outcome. This is the ideal for studying a real exposure or disease and can provide strong evidence of association. Retrospective cohort study is the research use existing data to identify the group of people exposed to past exposure and track their outcomes. Data is collected after the outcome being studied has already occurred. Groups are then followed to examine the development of disease outcome. So the advantages, they're stronger for establishing causality and study multiple outcomes. Randomized controlled trials, these are the RCTs, and this is the gold standard. Random assessment, which we randomize participants have an equal chance of being assigned to an intervention or control group, and this to eliminate selection bias. The control group provides comparison to separate treatment effect from the natural course of the disease or placebo effect. In the blinding is a single blind participant unaware of assignments. Double blinded, it's when the researcher and the participants are not known, neither know the assignments. The randomized trial is the most rigorous and powerful tool we possess to determine the effectiveness of clinical interventions. the common methodological challenges and bias and confounding. So we do have, I just picked the most random ones that we have and the one that we usually come through the most. So selection bias is a systematic difference in how participants are recruited or assigned to groups. Example, study heart disease only in hospital patient misses milder case, which we miss the milder cases. Solution, how do we avoid falling within this bias is we randomly sample and clear defined inclusion and exclusion criteria. We also do have an information bias. It's an error in measurements or data collections that create false association. Example, recall bias is when cases remember exposure better than controls. So the solution for that is standardized measurement protocol blinding validated instruments. Confounding is the external factors distorting the true relationship between exposure and outcome. Example, age affecting both risk factor and disease. And solution is randomized match stratification and statistical adjustment. The role of planning and execution. So clear objective, well-defined research questions and hypotheses guide appropriate study design selection. Rigorous sampling is representative population selection with adequate sample size calculation to ensure statistical power. Statistical analysis is pre-specified analytical method appropriate to study design and data. Ethical oversight is IRB approval, informed consents, and data security measures to protect participants. In conclusion, mastering clinical research methods for better health outcome is scientifically impact understanding and applying robust research methods in critical to advancing medicine and distinguishing true effect from statistical noise. Methodological rigor is thoughtful design, awareness of bias, and ethical conduct lead to trustworthy evidence that can withstand security and replication. Patient safety, these methods ultimately transform scientific questions into life-saving knowledge, improving clinical practice and patient outcome worldwide. The journey from clinical question to evidence-based practice require mastery of these foundational research method. If anyone have any question, does that conclude my presentation?
Thank you, Dr. Eiman.
Thank you for your time. Thank you.
Yeah. Okay, if no question, going to the next agenda is giving feedback to juniors and others. Dr. Ahmed Khalifa. Sorry. Dr. Ahmed.
Yes, I am here. Can I share my screen?
Okay, sure.
Okay. Can you see my screen?
Yes.
Yes, thank you so much, Dr. Hagar. And I also want to thank Dr. Eiman for her kind invitation for me to speak to you today. I also want to thank Dr. Nader for his continuous guidance and support. My topic for today is about giving feedback to juniors and others. Supervising juniors is not a simple task. We usually thought giving feedback is a simple task, You just tell them what to fix, right? But you quickly learn feedback is more than pointing out mistakes. It's about guiding, encouraging, and helping someone grow. Today, I want to share a simple but powerful tool we often call the criticism sandwich. So let's start with a question. Have you ever been on the receiving end of the criticism sandwich? Maybe you didn't even realize it at this time. It's when someone starts with something positive, slips in the criticism, and then ends with another positive. This is what's called the criticism sandwich. But does it always work the way we think? Why feedback is tricky in medicine? In medicine, feedback is tricky. We deal with sensitive situations, high stakes, and emotions. The way we deliver feedback can build trust or break confidence. It's not just about what we say, but how and when we say it. Resident junior supervisors often deal with situations where they need to deliver difficult feedback. Common situations: missed important step in history taking, skipped finding in examination, gaps in patient management. In these moments, the way we communicate feedback can make the difference between discouraging someone and helping them grow. The criticism sandwich. So here is the basic recipe. Start with praise, insert the constructive feedback, and then close with encouragement. It's simple, memorable, and widely used. But like any recipe, it has its strengths and weaknesses. The key benefits of criticism sandwich. The first benefits, as we see here in the slide, it reduces defensiveness and encourages receptiveness. It softens the blow. People are more open to hearing criticism when it's wrapped in positives. So, start and end with positives, less likely to feel attacked, and soften criticism, increase openness, and encourage receptiveness. Feedback framed positively, it will become easier to accept and promotes constructive rather than confrontational tone. So, to simplify this, it softens the blow. People becomes open to hearing criticism when it is wrapped in positives. Can you see my screen?
Yeah, we can see, but we cannot hear you. I think your voice is cutting or something. Hello?
Yes, can you hear me now?
Now, yeah, we can hear you.
We are now speaking about the key benefits of criticism sandwich. The first benefit, it softens the blow. People are more open to hearing criticism when it is wrapped in positives. Second one, it maintains morale. You remind them of their strengths while pointing out areas to improve. Positive keep the person motivated, balances criticism with recognition of strengths, and also strengthens relationship. Shows that you value their effort, not only mistakes, and builds trust through fairness and empathy. The third thing, that it encourages continued effort because they leave the conversation still feel valued. Clear, structured delivery ensures criticism isn't overshadowed by negativity and promotes growth mindset, focus on improvement, not flaws, frames criticism as opportunity for development. So, to summarize these benefits, it softens the blow, makes the people open to hear criticism. Second, it maintains morale. You remind them of their strengths while pointing out areas to improve. And the last thing, it encourages continued effort because they leave the conversation still feeling valued. It's no surprise managers and mentors have leaned on this for years. But here is the catch. People can start to see through it. If every positive comment is just a setup for criticism, it feels fake. Others may even ignore the praise completely and only remember the negatives. So, while useful, it's not a one-size-that-fits-all solution. So, when to use the criticism sandwich? That's why we should be intentional. The criticism sandwich works best in performance reviews, mentoring conversation, team discussion, or sensitive situations, where moral really matters. It is not the only way to give feedback, but it's a good tool for the right time and place. Now, feedback is not just something we give. We are not usually or always the one who give the criticism. Sometimes you receive the criticism. So giving feedback means guiding and supporting others. Receiving feedback means reflecting, learning, and growing ourselves. Mastering both sides transform feedback into teamwork and excellence. If you are receiving a feedback or a criticism, how to diffuse your own defenses when triggered? When you are facing a criticism, normally you are triggered and you will try to open your defense mechanisms. But let's be honest, receiving criticism isn't easy. Our natural reaction is to get defensive. The key is pausing, breathing, and listening with curiosity. Instead of thinking, they are attacking me, try asking, what can I learn from this? That shift makes criticism a growth tool, not a threat. For example, one trigger, you feeling criticized. You justify, over-explain, or get angry. Instead, try to diffuse. Pause, breathe, remind yourself. It's just their perspective, not always an attack. Another example is feeling dismissed. You feel small or want to withdraw. The best action is to validate your feelings. It's okay to feel hurt. Affirm yourself, my voice matters. Another example, feeling controlled. You resist, argue, or dig in your heels. The best action is ask, is this really about control or about feeling unseen? Focus on what you can control. Another example is feeling misunderstood, and you will try to over-explain or become defensive. But it's better to reflect. Do I need to be understood or can I let it go? Sit back. It's okay if they don't get it. So the next time you give or receive feedback, remember it's not about criticism. It's about growth. And with the right approach, feedback can strengthen not only individuals, but entire team. Thank you so much.
Thank you, Dr. Ahmed, for raising this topic. Yeah, it is very important. I think resident in the first year, the interns, they ask them to do like feedback for each other, not only seniors, but only between residents. Yeah, thank you so much.
Yes, and so it circulates. Sometimes you will
Yeah.
give criticism, and the other hand, you will receive the criticism.
Yeah, thank you.
And I want to thank Dr. Nadu for this idea. It is a new idea for me, and thank you so much.
Yeah, it is very important. Sometimes they ask in the interview also about how do you deal with, how do you give feedback, or how you do accept it, or how you deal with criticism.
Yes.
Okay. Yeah, our last topic will be about their stories. Will be presented by Dr. Niaam Adam. Dr. Niaam.
Hi, how are you, everyone? Am my screen visible?
Yes.
Okay, so thank you, Dr. Nadir, for providing me such opportunity. I hope you are doing well, and as well as other fellows. Successful IMG's stories. So today I am really excited to share this topic with you, as those stories, they are real stories of struggles, resilience, and success. As IMGs, their pathway usually is not straightforward, as many of us nowadays facing ERAS application challenges. So they face the real world about the USA residency application. So hearing those stories and watching their setbacks and realizing their failures and their multiple attempts that they have done, reassure that we are not alone and the success is possible. So why IMG's story matters? As we see here, there is a graphic representation from FSMP 2024. They are showing that there is a rising number for IMGs attending to US healthcare system. They represent almost 23%, and this is not a small number that trying to squeeze to the system, but they're an important part of the physician workforce. So what are the common challenges for IMGs? IMG's journey is tough. They are prone to deal with multiple exam attempts.
Sorry, Dr. Niaam.
Okay.
Your slide is not moving. Can you?
Is it
try?
moving?
No.
Okay. Is it visible?
We can see only the first one. Yeah.
Okay.
Mm,
Is it moving?
yes, yes. No, yes.
Okay. So returning back to what I said about why IMG's story matters, as you see here, according to FSMP, there is a rising number for IMGs in comparison to non-IMGs. They're estimated 23% of the USA healthcare system. And I said that this number is not a small number of physicians trying to squeeze into the system, but represent a huge physician workforce. Next, we have a common challenges for IMGs. Usually, IMGs have to experience multiple exam attempts. Nowadays many immigrants facing the visa delays and restriction, the ban. Also, they may face a limited US clinical experience, along with a high competition for residency spot. But knowing these challenges would help us prepare for our each cycles and support each other through them. Okay, lastly, we didn't forget the financial burden for the pathway. So what are the keys for success? IMGs usually share common things for success, usually by persistence and not giving up, and keep going through each cycle and use each cycle as a learning tool instead of a final pass that they didn't get matched. Also, one of the keys some IMGs they get involved in the USA clinical experiences and get engaged with some research and fellowship opportunities, and or seeking mentorship and enhancing their networking. Most importantly, most IMGs they use flexibility keys while applying through programs. So there is here's the first step of IMG story called Martin Lino. Martin Lino, who faced visa delays, as apparent here, and he had multiple exam failures. So his turning point where he tried to engage in the research and observership opportunity. So at the end, he succeeded to get his IMG, his residency spot by persistence and continuous learning. Where our second example would be Ojing Osana. Ojing Osana, she has previously she has a narrow focus while applying Sura and choosing the programs, and has initial multiple residency application failures, but she switches her application program to other different and broaden her choices. So by this flexibility in a specialty and location opens various opportunity to herself. So here I attached this link. It's contained countless stories for IMGs that can be used to help us being in touch and help us that we are not alone and we are not isolated. And it's a reminder that no single way is to succeed. So lessons for aspiring IMGs. So all of us, as I said, we're facing nowadays ERAS applications. We should stay engaged by research and volunteer opportunities, and then seeking for mentors, be flexible with the programs and plans. So, and try to get as much as information from each cycles. We do not let any failure define us. So here, how we can benefit from our fellowship, telegeriatric research. The fellowship provides research skills, mentorship programs, as we now experiencing, and team learning base, as well as letter of recommendations. So finally, every IMG's story proved that perseverance, obstacles, and stepping stone. Thank you so much.
Thank you, Dr. Niaam. Hopefully next year we come and see our stories also, inshallah.
Inshallah, inshallah.
Yeah. Okay, any comment? Before we move to the last agenda? Okay, thank you. Thank you all the presenters. Our last thing, if anyone has update or project need to discuss with Dr. Nadir. Any ideas?
We do have a project that we're working on as a great team. Is it okay that we can talk about it?
Yes, I think Dr. Nadir is here, but he has a problem with the voice, I think. Yeah, yes, you can go ahead, Dr. Eiman.
Okay, so I just want to update on the systematic review research study that we're working on, titled Early Prediction of Sepsis in Post-Stroke ICU Patient Using Artificial Intelligence. So we are now at the beginning steps of reference and collecting data. And what we are right now on the screening phase of that systematic review project, and that's about it.
Thank you. Thank you for the update, Dr. Eiman.
Thank you, Dr. Hader.
Anyone else have any updates or new ideas you want to discuss? Go ahead, Dr. Muhammad.
Hello everyone. Assalamu alaikum. My name is Dr. Muhammad Omar. I'm new fellow here. It's nice to see you guys. I'm working on app called Got Easy. It's an AI companion for IBS patient. The core features of the app contain daily logs, symptoms tracking, the daily symptoms of IBS like bloating, diarrhea, constipation, and so on. Monthly tracking, including anxiety scales, depression screening, and so on, IBS scores, and medication adherence. I want to share it with you, if you don't mind.
Sure, you can. Dr. Niaam, you can stop your screen sharing so he can.
For a minute.
Dr. Muhammad?
Okay, 1 minute, I have connection
Okay.
issue.
Okay, take your time. Sorry.
Can you see my screen now?
Yeah, yes, we can see.
Okay. This is the welcome page of the app. You can create your account here, sign up. You enter this information, your name, let's say Muhammad, your email address, creating password, your age, your gender, your IBS type, if it is diarrhea predominant, constipation predominant, mixed, or unspecified. Let's select constipation predominant. Diagnostic date. Let's select any date. And the medications. Medications, current medication, regular medication, and bare need. Let's select libromide, probiotics, PRM medication, peppermint oil. Create account. Enter your age here. Email address already. Create account. We have daily tracking. Daily tracking, it's for symptoms. The patient should enter every day and report their symptoms. Bowel movement. Is it urgent? Not urgent? The degree of urgency. Let's say severe urgency. Number of bowel movement. Let's say 1. This is the severity of symptoms by this scale from 0 to 10. Abdominal pain, bloating, diarrhea, constipation, gas, nausea. Here we have stool type. The patient should select the type of his or her stool from the Bristol stool. Let's say type 2 stool. Sleep and quality duration, let's say 7.5 hour. Quality, good sleep. The warning sign of IBS. If the patient had warning sign or not. Let's select this. The food intake for today. Let's select dairy, spicy food, sugars. The mood of the patient. Let's say low mood. Water intake, exercise and physical activity. None. If the patient have any additional notes, you should write it here. Saving. If you select one of the warning signs, this will appear to you in the saving. Warning, you reported serious symptoms. Blood in stool, severe abdominal pain. This may require immediate medical attention. Have you contact your healthcare provider? Click OK to save the log or cancel to review it. Let's say I contact my doctor. Okay. Here's my log is saved. It's saved here in the daily logs. We can find it here. Okay. My logs, sorry. Daily logs 1. Average severity 10. Good days 0. Trigger found it 3. The next item is monthly check-in. Monthly check-in including 3 scales. Generalized anxiety scale screening and depression screening and IBS health screening. The patient should do it every month. How has IBS affect your quality of life in these months? The patient should respond to this question. How often did you experience symptoms? Here are the depression scales. Depression scale 2 question. The patient should answer it. Mental health screening and anxiety GAD7 scale 7 question. The patient should answer it. Here the patient should enter the application or website daily to report their symptoms and food intake, and monthly to do this screening test. Okay. After that, we have here the insights. The AI generate insights according to this data. Dietary suggestions, lifestyle tips, and weekly pattern. What is the most frequent trigger? What is the most predominant symptoms? After that, when the patient want to go to the doctor, he can generate and download medical report by this data. Download medical report. This app, this version is very primitive. I work on it. I think this version is very complex. I want to make it simple and easy to be used by the patient. Thank you so much.
Yeah, excellent. Excellent, Dr. Mohammed. Yeah, so you work on it by yourself, or do you have group or a team like, or?
No. I work it on by myself. If anyone
Mm,
interested, he can contact me. I will put my email.
Okay. So do you follow the steps in the group, like in the previous meetings or Zoom meetings, or you just go to Google the steps and do it, or?
I do it on Canva. The
Okay.
whole application I do it on Canva.
Mm-hmm. Okay, thank you. Because we have like for new follows, if you go to the previous Zoom meeting, you can like watch how the steps how to build apps. Because one of the areas that you can as we know in this fellowship, we work in different projects. Some people work in research. You can also work on developing applications. For developing application, we can you can go back to the previous Zoom meeting and see how you do that.
Okay,
Yeah.
I will check it. Thank you.
Yeah, thank you so much. Yeah,
Thank you.
it's very nice.
Hello, this is Dr. Nader again. Thank you, Dr. Mohammed, for the showing your app. Thank you. This is great idea and good work.
Thank you, Dr. Nader.
Anybody else? Anyone else?
Hi, Dr. Nader.
Hello.
How are you?
Very
I'm
good.
Marwa.
How are you, Dr. Marwa?
Thank you. Dr. Nader, regarding our app, I would like to give you an update about
Yes,
it.
please go ahead.
So, Rana is not here today, but like she has the original app, but I can show you a recording she sent me yesterday.
Sure.
Okay, so let me just share my screen. Can you guys see my screen? Hello?
Yes, we can. Yes.
Okay. Okay, so I will show you the video. So you sent us a code to allow the camera to have access to the app. So it worked, and here, okay, so let me just show you. So sorry, let me just start the video from the beginning. So Rana, okay. She took a picture of the medication. Okay. And then immediately the photo uploaded to the app. But the problem is with recognition. So the app didn't recognize the drug. She has tried to take the picture multiple times. This is the second time. Okay, so third time it identified warfarin as ibuprofen. Okay, this is the fourth time. in this time, the drug was identified successfully. And then the form was filled automatically. These are the side effects. Medication. And that's it. So, like, I think it's like we made a great like progression with being able to upload the photo directly without without the need to do 2 steps. And like I've been working on recognizing the name, but like it didn't work at all. Like I've been working on it for the last 3 or 4 days. So if you have any idea, you can give us an idea on how to solve this problem.
Hello, Dr. Marwa. So thanks for sharing. Dr. Marwa and Dr. Rana are working on this app to help their patients. So this is a very big step that at least you have the camera, you can catch the image, and the issue with the recognition. I think there are different what they call OCR that recognize the fonts and then translate that into text. So OCR, I'm not sure stand for what, but it's the program that recognize the image, translate the pixel into letters, and then formulate what's could be the most common word out of these letters. So sometimes these programs might be primitive, but we want to see if there is an updated version, or maybe the AI itself, they have their own image recognition. So it's going to be a next step to figure out how to convert the image into text correctly. That's one option, which is we will try to find out an AI that's helpful in this area. The second option, I think in the US here, most of the bottles of the medications, they will have a barcode. It's similar to when you buy stuff, you want to buy a shoe or you want to buy something, they will have a scan that can scan the barcode for each item, and it will show what the price for that item. So maybe that might be the easier option if we can figure it out with the help of the AI also to scan these codes and barcodes and see if it will bring something. I might be mistaken, but this is what I think the other option. But you did great. Excellent.
Thank you, Dr. Nader. Like you sent us the code, and me and Rana, like when it worked, we didn't believe it, because we didn't believe that like the app can directly upload and have access to camera. So without your code, we this progression. You are the one who did this progression.
So it's kind of just building on each step that you are taking, and this is what I'm interested in, is getting you guys making a team, and then add some of the other fellows so that you can work together and give each one an idea and share these ideas, and you can try and maybe figure it out how to solve every issues that you face. But so far, I think the app is in its beta version, so you can test it with other fellows, get a team and see what they think, and they can try it in the US, in Saudi Arabia, in Egypt, and so on, and see. The first step is to see if we can figure it out using an AI that can recognize images, convert it into text using the OCR method. I think there must be one. I have no idea. I haven't tested it, but I know the old version. In the past, we used that.
Okay. Also, Dr. Nadir, my brother, he works, he's a software engineer, works for Google Gemini in London. So I will ask him if he can help us with this
That would be great.
system. He's a little bit busy, but I will try. I'll try to force him to do it for me, inshallah. If I make any progression, I will let you know. Like I will send you an email.
Sounds good. Sounds good. Thank you so much,
Thank you.
Dr. Marwa.
Thank you, Dr. Nadir. Also, Dr. Nadir, I have another question regarding updating the agenda in the app. Like Dr. Eiman today have sent me some of their slides. I was able to update some of them, but the agenda, it allows me to update up to 5 files. I couldn't upload the last one. Like I was really afraid to do something.
Sure. I will update the app so that it can accept more than 5 files. That's easy to do. Yeah.
Okay.
Thank you so much.
Thank you.
You're welcome. Yeah. Great. Thank you so much. Anyone else would like to discuss, or anyone with any questions regarding the fellowship itself, any projects, new ideas? Just a reminder, if you are planning to use ERAS for this round or season, please use the app so that you can request a letter. When you do that, you will give me an opportunity to write a personalized letter for you. So if you use the app, you can add whatever activities that you have, and then use ERAS to request the letter for the specialty that you would like to apply to, for example, internal medicine, or if there are more than one, you can send me more than one request regarding the specialties that you are applying to.
Thank you, Dr. Nader. I just want to ask if you received my request. I sent it a few days ago.
Sorry, Dr. Ahmed, can you, your voice a little bit far away? Can you just...
First of all, thank you so much. I just want to ask about my request. If you received my request, I have sent it a few days ago. I just want to make sure.
That's a good question. Yeah. Regarding the conference, the webinar, or something.
I am asking about the ERAS request.
Can you ask me the question here, or show me the email again? Because I don't see. Maybe.
Are you hearing me, Dr. Nader?
Yes. Can you hear me now?
Oh yes, I am hearing you clearly. I am asking about the ERAS request.
So you send me a ERAS request, or you ask me about?
Yes, I have sent a request.
Oh yeah. I see the request.
Okay,
yes.
I'm just to make sure that you received the request.
So I got the request from ERAS, but
yes.
did you work on the app?
Yes, I sent also a request from the
All right. That's then I will write the letter. I was working on some of the other letters requested by other fellows, but I see your I'm running behind, so I will do it.
Thank you so much. And as regards the seminar, I have sent you an email
Yes.
with the assigned speakers and still to decide the exact date of the seminar. Inshallah.
Okay. Do me a favor, after you decide, or maybe now, if you want to ask some of the fellows, maybe one of the fellows in this group, to work on getting what we call like a template for announcement or advertisement or flyer, like you put the title of the seminar, the names of the presenters or their images. You can use Canva for that. So if there is someone who is good with creating such a thing, maybe they can help you.
Okay, doctor, I will write my number, and if anyone is interested, he can contact me on WhatsApp.
Sounds good. Thank you so much.
Thank you, doctor. Thank you so much.
Thank you. Anyone else or any other questions? I see there are some people who are interested in, I think, the topic before. So if someone can look at the chat and get back to these fellows, that would be great. So if no more questions, I'd like to thank you all for attending this meeting. Thank you all the presenters for great presentations. Thank you, Dr. Hajar, for moderating this and helping with the team and the presentations. Dr. Marwa, thank you so much for keeping this in line. Thank you, everyone, again. And if you have questions or need any help, please reach out, send me an email or text or WhatsApp. We'll try to help you as much as we can, and we wish you all the best. We'll see you next week. Assalamu alaikum wa rahmatullah. Fi amanillah.
Alaikum assalam wa rahmatullahi wa barakatuh. Thank you.
Thank you, Dr. Nader.
Thank you.
Thank you, Dr. Nader.
Thank you so much.